And yes, can everyone else?
Yes.
Yes.
Okay, so do you want me to present from my slides or?
That's probably easiest, Dr. Chen, to be
Okay.
honest with you.
All right, let's see.
And we are recording Dr. Chen separately from the meeting because we want to be able to use this as a training tool.
Okay, hang on a second. Oh, and where are my notes? Hang on a second. Oh, there they are. Okay. All right. So, so hopefully this will be a quick talk. So yes, we are going to record this for the purposes of accreditation and hopefully building a library of educational videos. Okay. So, so very quickly, monkeypox is a misnomer. It's so it is a disease caused by a monkeypox virus. It is a bit of a misnomer. Most of these pox viruses, except for smallpox, are carried by rodents, so mice, rats, things like that, who then transmit it to other hosts. So the CDC has updated their pictures just this week. They've been updating a lot of pictures and their entire website on monkeypox. So we now have pictures of monkeypox on different skin tones, which is very useful. Okay, so the monkeypox was first discovered in 1958 in colonies of monkeys that were being kept for scientific research, and wasn't found in humans until 1970. So the history is basically during the eradication of smallpox, they were finding people with a disease that looked like smallpox, but had no smallpox contacts, and that's when they realized it had jumped to humans. So for the most part, monkeypox has been limited to Africa as well as to travelers from there, and then there was a large outbreak in the United States several years ago, which I'll talk about. We don't know exactly which rodent harbors this in nature, but it is, we believe, some sort of mouse, rat, or squirrel. Okay, so this is a picture from the CDC. So essentially, monkeypox seems to be increasing because smallpox vaccinations did protect against it. So as that immunity wanes, we seem to be seeing more of it. So over the last couple decades, you can see it spreading. And the biggest current outbreak is in Nigeria, which has been going on for about 5 years now. So there are several hundred cases either confirmed or suspected. In that outbreak, there was a report of about 3% mortality. That's probably a high number because there are probably a lot of milder cases that never reach medical attention. And again, we've seen cases in the United States, UK, and other countries of people who traveled from Nigeria. Okay, so the current status now. So this current outbreak seems to have started around May 7th. So probably some unrelated cases in here, but in May 7th, the UK reported a case in a traveler who had recently returned from Nigeria. So that, I think, increased awareness. On May 14th, they found 2 more cases, and these were not related to this traveler. And then they started looking even more and found 4 cases. And this is when I think things became fairly concerning. So these are 4 cases with no contact to any of those 3 other cases, but they were all men who had had sex with men, so either gay, bisexual, or other. And since then, we have I think over 300 cases now. So this slide was, the slides I had updated yesterday morning, but now we have over 300 cases worldwide that are confirmed. Again, nearly all men. I think there are maybe one or two women in this who are being evaluated. I'm not sure any female cases have been confirmed. And in the United States, so yesterday we had 3 confirmed and 1 presumptive, and then late yesterday, they updated to 9 confirmed cases in the United States. So numbers are rising rapidly, and I'm not sure that is in itself a reason for concern. I'll talk about that later. On the right side, there are some nice pictures from the United Kingdom of the stages of the rash, working their way from just an early vesicle, small vesicle, to pustule, to an ulcerated lesion, and then the scab, which then eventually falls off. Okay, so so we have again some history in the United States of monkeypox. So there were a few cases that were related to travel in the past. Those were all confined to the traveler. Nobody else on those flights were infected. But the big outbreak here was in 2003. So there was a shipment of rodents from Africa. So apparently mice, squirrels, rats, and these were housed next to prairie dogs, which were then sold to the public. So that led to probably 47 cases that we know of. The blame was placed on the Gambian Pouched Rat, also called the African giant rat. There's a picture in the bottom right, if you're able to see that. These were being kept as pets and are now banned. And if you wonder why people would want a giant rat as a pet, this particular rat was actually a minesweeper in Cambodia and found over 100 pieces of unexploded ordnance. So they are actually apparently useful. And apparently they also, even though they're banned in the United States, some escaped in Florida prior to the ban and are now invasive. But anyway, getting back to the outbreak. So there were many people hospitalized, but only 2 really serious illnesses, both in children. One child had encephalitis and had to be hospitalized for 14 days. The other had very bad oral sores and could not eat or drink. In fact, they said had trouble breathing. I don't know exactly how long that child was in the hospital. I've read that they both fully recovered. I don't know if that's absolutely true. And then I think many of the adults who were hospitalized were kept in the hospital mostly for infection control purposes. Okay. Transmission. So the monkeypox virus is not particularly transmissible. Many of the cases, again, in the prior U.S. outbreak, were from the animal to humans. So many veterinary staff or some pet store staff. Again, children, I'm not sure if the children just had much more contact with the pets or if they're normally more susceptible because of their age. But you can see that people have gotten it from scratches, from hunting, possibly from bedding of the animals. Human-to-human transmission has in the past been the vast minority of cases, but seems to be the main transmission here. So usually requires, I think, large respiratory droplets, so much less transmissible than, say, COVID. Requires direct, prolonged face-to-face contact. As far as I can find, there was only 1 report of a healthcare worker becoming infected who was not wearing PPE. And then there's some concern about linens, so you don't want to shake bed sheets out, things like that. There's 1 report of a congenital monkeypox case. So the incubation period for monkeypox can reach up to over 3 weeks. Once you do become sick, the entire course of the illness can last up to 1 month or so. So usually these are people who have a fever followed by oral sores, then a rash, and then there's other systemic symptoms: fever. I'm sorry, headache, muscle aches, back aches, chills. One of the interesting things is that smallpox typically does not have lymphadenopathy. So people with monkeypox who have lymph nodes, usually that's a good way of determining that that is monkeypox and not smallpox. This is just a slide about the course of the disease. Again, you start with the onset of a fever, malaise, and then you get the oral sores, and then you get flat and then raised lesions, which then eventually turn into pustules and scab over. Okay, in terms of how to deal with this, so if you do encounter a suspect case in the office setting or hospital, so the person should be placed in a private room. The healthcare worker should be wearing an N95 mask just in case, but mostly the CDC has said that you really want to be on airborne precautions just in case it's smallpox and not monkeypox, until we absolutely rule that out. But a negative pressure room, if available, is a good idea. And then the usual contact and standard precautions beyond that. Again, you don't want to have, you want to be careful with linens and other objects that have been in contact with the person. Okay, this is in terms of exposure. So there is, for people who are at high risk, we do have a post-exposure prophylaxis now, and I'll talk about that. That's basically vaccination with a smallpox vaccine. I'm going to move along. I think the interesting thing here is to note intermediate risk is basically somebody who goes in, if you have a healthcare worker who isn't wearing at minimum a surgical mask, then that's an intermediate risk. If you have a surgical mask on, you're considered low risk. And I think that's the most important thing I wanted out of these slides. Okay, so treatment, there's not any human studies on monkeypox treatment per se. There are actually, but the UK has recently published a little data on prior treatment. So right now, the mainstay is going to be vaccinating with the smallpox vaccine. According to old data from the 70s, it appears to be about 85% protective, and the UK and France have started using post-exposure prophylaxis, and I believe that they're doing that in United States also. So the main one will be this, the vaccine called Jynneos. It has a couple other names in other countries, which I've listed. It is a non-replicating vaccinia virus, so it's been modified so that it cannot reproduce. The older versions are, what's available in the United States is something called ACAM 2000. That's a live virus, and it could spread to other people. So, so they're trying to avoid using that, but we do have large stockpiles of that one. In terms of antiviral treatment, so there are some older medications that have been used for CMV and transplant patients. These are cidofovir and brincidofovir. When used in monkeypox patients, it does apparently cause some liver abnormalities. The newer one is tecovirimat, which is available in the national stockpile for smallpox. Its brand name is TPOX. And there is a vaccinia immune globulin, which I don't think I've seen anybody using right now. So the main health concerns in terms of public health, so we think this is a fairly low risk virus. So so most of the time, it does not have long chains of human transmission. And the rapid rise in cases probably reflects late recognition, I think, than rapid spread. Although we do want to stop the spread that is going on. The risk to the general public's currently low, and because most of the cases are concentrated among the MSM community. Again, there are a few cases in household contexts that we need to watch. And then if, looking forward, what I am concerned about is people who have uncontrolled HIV. So if you looked at there's a case series in Nigeria from a few years ago. More than half the deaths were in people who had HIV who were not taking medications. And then anybody else with an weakened immune system would also be at high risk. And then if you have nosocomial spread in healthcare, I think that's something that I'm concerned about if people are admitted and don't, it's not caught quickly. The other thing that may be impacted is congregate care facilities or congregate living facilities. So we may need to have a plan going forward in case we see cases there, because the isolation period is until the scabs are healed, which takes a few weeks. So so that's all I have right now. Happy to take questions.
Dr. Chen, this is Dr. Haverlack.